Welcome back. This we continue with brain injuries, and now in this class we're talking about the systemic complications or changes that happen with major burns. So when there is a major burn, nearly all the systems in the body are going to respond. They are going to be affected. So when you look at the circulatory system, there's going to be number one, hypovolemic shock, because for major burns greater than 15% of the total burn surface area, there's going to be massive plasma loss because of the capillary leakage. And that is going to lead to reduced cardiac output, hypotension, poor tissue perfusion, all right? And all this, okay, is going to be leading to problems. Remember, there is leakage of the capillaries. What happens if there is leakage? You are losing fluid in the vessels. What happens? There's going to be hypotension. What happens? The tissues will not be receiving enough blood. What happens? There is poor tissue perfusion, and that leads to mouth organ failure. Okay, that is what happens. So for a burn shock, there's going to be hypovolemia, and then there's going to be the systemic inflammatory response syndrome. Okay, and then so what is really causing the burn is either the shock is either hypovolemia, a reduction in fluid, or distributive shock, where the infection gets to spread in the rest of the body, and that causes a systemic inflammatory response syndrome. Besides that, the cytokines that are going to be released because of the burn will also cause the systemic vasodilatation, which causes also capillary leak, and then it will cause the hypovolemic shock. Okay, so that is what happens. Another problem on the circulatory system is fluid and electrolyte imbalance, because what happens is that these the sodium is also going to be lost. Okay, that leads to hyponatremia. And what happens is that, well, the calcium, the potassium is more inside the cell, so you are losing fluid from the inside of the cell. So the potassium is actually remaining a lot of it. Okay, so it is actually going to be, you are going to have hyperkalemia, and then metabolic acidosis is also going to come in. So the sodium is low, potassium is high, acidosis is coming in. There's also going to be the deep venous thrombosis and pulmonary embolism. And this is because for someone that is in shock, I mean, someone that is having a burn, they are more bedridden. They are not moving because of immobility and the hypercoagulable state because of the burn itself. There's now going to be the deep venous thrombosis and pulmonary embolism, and these are bad. These are bad conditions. Another problem that comes in is edema. That is because the same shock, okay, when the vessels are dilating and then fluid are seeping out of the vessels, that leads to edema. And then there's also going to be hypoxia. The red blood cells are going to be destroyed because of the thermal injury, and that leads to their inability or reduced ability of oxygen to be carried in the body. Okay, and also the pulmonary edema will cause impaired ventilation, and that all will lead to hypoxia. Hypoxia is basically a reduction in oxygen delivery. Okay. Another problem that happens is the toxic shock syndrome. It is also shock, but this is toxic. It's because of infections. Okay, secondary infections, basically caused by Staphylococcus aureus. Staphylococcus aureus will produce what we call exotoxins. These exotoxins are specifically the toxic shock syndrome toxin 1, okay, TSST1. That toxin is what is going to lead to the toxic shock syndrome. And what happens, this one is more common in children. So children will present with fever, a rash, hypotension, and mouth organ involvement. When we look at the GIT, the changes that happen on the GIT, you have got fluid and electrolyte imbalance, and also are going to have other. Okay, not the GIT, but the genitourinary. Okay, we'll start with the genitourinary. So I'm going to have fluid and electrolyte imbalance, and then renal changes. So for the fluid and electrolytes, there's going to be dehydration, and that is because of the reduction in the intravascular volume, the reduction in plasma volume. And then there's also going to be electrolyte disturbance. For example, there's going to be hypernatremia. Okay, the sodium is going high because of water loss. So if so, a lot of water is lost, but little sodium is lost. So what happens in that case is a lot of sodium has remained. That's why the hypernatremia is coming in. And then there's also hypokalemia. Potassium losses is going to happen in urine. So you can see that that's actually opposite to what we talked about on the secretory system. So hypokalemia is going to come in. And then hypocalcemia, calcium binding to damaged tissue is going to get to happen, and so that leads to hypocalcemia. Okay, the calcium is dropped, and then some renal changes is also going to happen. So hormonal response to hypovolemia is different because when someone is losing a lot of fluid, the body releases hormones to respond to that loss of fluid. There's going to be increase in the antidiuretic hormone being released from the posterior pituitary gland, and this causes water reabsorption by the kidney. And then there's also going to be an increase in the release of aldosterone from the adrenal cortex, and that causes sodium reabsorption and potassium excretion. So the potassium again being excreted and sodium is being absorbed. That will worsen hypokalemia and hypernatremia. And so there's going to be oliguria, which is a reduction in urine output. There's going to be prerenal azotemia. This is basically where you have got urea, which is going to be increasing. And then there's going to be acute renal failure, okay, because of secondary hypoperfusion. There is no blood going to the kidney that leads to acute renal failure. There's also going to be myoglobinuria, okay, from the breakdown of muscles. You are going to be able to see myoglobin, breakdown products of muscle in the urine, and there's also going to be sepsis. Okay, so that is what gets to happen on the respiratory system. Because of fluid seeping out of the pulmonary vessels into the lungs, there's going to be pulmonary edema, and then respiratory infection is also going to happen because immunosuppression actually gets to happen because of the systemic inflammatory response syndrome. Okay, there's the weakening of the respiratory, there is the weakening of the immune system, and that leads to pneumonia, infection of the air of the respiratory tract. There's also going to be the adult respiratory distress syndrome. Okay, and this one is seen because as a response to hypoxemia, there is a reduction in oxygen delivery to tissues, respiratory failure. Okay, not really as a response to hypoxemia and respiratory failure, but when there is severe inflammatory response in the lungs, because remember we've talked about the systemic inflammatory response syndrome is happening in the entire body. So the body is reacting, releasing cytokines, and once these cytokines have been released, also in the respiratory tract, the airways are going to be becoming smaller, okay, vasoconstricting. I mean, not vasoconstricting, but bronchoconstrictions, and all that which will lead to hypoxemia and respiratory failure. That leads to adult respiratory distress syndrome. For inhalational burns, they can also cause airway edema, obstruction, and respiratory arrest, and someone can just die. So for infections, someone is going to be predisposed to infections because there's actually immune uh, dampening. So for someone is going to be predisposed to getting bacterial infection like Staphylococcus aureus, beta hemolytic streptococcus, Pseudomonas aeruginosa, Klebsiella pneumoniae. Okay, all these infections will lead to the bacteria moving in the body, leading to bacteremia and septicemia. Fungal infection and viral infection can also come in because of weakness of the immune system. So there will be opportunistic infections, okay, because of post-burn immunosuppression. The toxic shock syndrome is also going to come in, and this is caused by Staphylococcus aureus, which is life-threatening and is more common in children, and so they will present with rash, myalgia, pain in the muscles, diarrhea, vomiting, hypotension, mouth organ failure, and this one has got high mortality if untreated. And then there's the post-burn immunosuppression, which actually causes these infections. On the GIT, what you are going to see is hypovolemia, the hypovolemia and mucosal ischemia. There's no blood supply to the GIT, so that will lead to erosive gastritis, okay, inflammation of the GIT. And then there'll be the Kelling's ulcers, also known as the Kelling's ulcers. These Kelling's ulcers, they are because of hypovolemia. So what happens that hypovolemia, there is a reduction in blood volume, so even blood supply to the GIT would have decreased. So there is little blood supply to the GIT, and we call that as ischemia, and that will lead to erosive gastritis. So for burns which are greater than 35% total burn surface area, you will not be able to see these Kelling's ulcers. These Kelling's ulcers are basically like peptic ulcers. They are ulcers in the stomach. So they are ulcers in the stomach, but they are not because of increase in the production of hydrochloric acid. They are just because of a decrease in the mucosal defenses. Okay, because there's actually erosion of the mucosa because of no blood supply, and that what causes the acid that is produced by the stomach. Okay, there's nothing to defend the stomach from that acid, so it becomes harmful. So that is what causes the Carling's ulcers. So we're not putting them as peptic ulcers. Okay. There's also going to be paralytic ileus. Paralytic ileus is caused by electrolyte imbalances that happen. This is where now the GIT cannot really be able to propel the content forward. There's also going to be bowel mucosa ischemia. Okay, ischemia is happening. There's no blood supply to the bowels, and so what happens is that there is poor motility, malabsorption, and the bacteria will just be moving now. So if these bacteria in the GIT now gets to move out into the peritoneum, there's going to be peritonitis, there's peritoneal edema, septicemia, there's also going to be compartment syndrome. Okay. Now the compartment syndrome is going to be more common with the musculoskeletal system, so we'll talk about it there. So the chemical injuries can actually lead to some other problems. Also, for example, alkaline will lead to the esophagus forming strictures. Basically, these are constrictions. Okay. And then for acid, they lead to pyloric stenosis. The stomach, the beginning of the stomach that connects to the esophagus, we call that as the cardia. And then the end of the stomach that to connect to the duodenum, there is the pylorus. We call that as the pylorus. And then there is the canal and the antrum. So the pylorus is going to be becoming smaller. Okay, it is going to be constricting. So because of acid, there is pyloric stenosis. Because of alkaline, there is a esophageal stricture. Okay, acids will also cause mediastinal injury on the skin. What you are going to see is the formation of an eschar. Okay, now, if this eschar is circumferential, like a eschar is basically dead skin that forms on the wound. I mean, dead tissue that will form on the wound, and it is a hard tissue. And if this dead tissue that forms on the wound is surrounding, let's say the arm or a tissue, what happens is that it affects circulation of blood, and that will lead to ischemia. Okay, and it actually leads also to what we call the compartment syndrome, because there's no that compartments, the way they are formed is in such a way that, let's say for our arm. Okay, let me talk of the even the arm. Just it has got two compartments. You've got the anterior compartment, which is you're going to have muscles that are going to be able to flex the upper limb, and then the posterior compartment with muscles that extend the upper limb. So what happens in that case is that when you have got what we call the compartment syndrome, there's no expansion of the compartment. Okay, because compartments are designed in such a way that they can expand when fluids are actually increasing, but because of this eschar that is surrounding this compartment, it cannot be able to expand, and that leads to what we call the compartment syndrome, and that's a problem because the tissues will actually be able to die. On the skin again, you can see a contracture, and this is a late complication. Okay, contracture. You can also see what we actually call ectropion. Ectropion is basically this, where you see the eye being affected, okay, the eyelid being deformed. And then there can also be microstomia, where the mouth gets to narrow, joint disabilities, defective hand function, growth retardation. For electrical injuries, they can also cause fractures, internal organ damage. They can also be hypertrophic scars or keloids, okay, which is basically because of the excess deposition of collagen when healing is happening. All right, and then they can also be what we call Majolin's ulcers. A Majolin's ulcer is a malignant transformation. okay, in chronic burn scar. So if you have got a burn scar for long, it can become malignant, become a cancer, squamous cell carcinoma, which appears decades, years later on. And then you can also have metabolic complications that happen in burn injuries, like hyperglycemia can happen. And the cause for hyperglycemia is hypercatabolism, okay, because of stress hormones. Actually, this is what happens also if someone is involved in an road traffic accident. They are so stressed. So stress hormones are released, and those stress hormone causes an increase in glucose. So when you measure the glucose levels of someone that is been involved in a road traffic accident, or someone that has seen a stressing activity, or someone that is waiting for exam results, or someone that has been involved in an accident, you'll be able to see that the levels of glucose are so high, because the stress hormones, okay, the catecholamines, the collagen, the cortisol, the glucose are released during stress, and that's why you can see hyperglycemia. Okay, and the way it happens is that there's going to be gluconeogenesis getting to happen, glycogenolysis getting to happen, insulin resistance, and because of these high levels of glucose will lead to poor wound healing, and that puts someone at risk of infection. Okay, if someone has been exposed to toxic gases, for example, carbon monoxide are produced from incomplete combustion. Okay, let's say you are burning charcoal, but then it is not burnt completely. Carbon monoxide binds to hemoglobin 250 times more than oxygen. So if you are in a room where there's something that is burning, this guy will be, it's a silent killer. It will bind to the hemoglobin, forming what we call carboxyhemoglobin. And it means that oxygen will not be able to bind to the hemoglobin, and that leads to impaired oxygen transport. And clinically, there's going to be headache, confusion, okay, there's going to be cherry red skin, which is of course rare, and then there's going to be hypoxia. And then you can also have hydrogen cyanide poisoning, which is produced from house fires, like burning plastics, wool, silk. And this one, the hydrogen cyanide blocks mitochondrial cytochrome oxidase, which is going to lead to because the cytochrome oxidase is important in the mitochondria for oxidative phosphorylation and the electron transport chain. So if it can't work, it means that oxygen you are not producing really, respiration is not continuing to happen, and that leads to cellular hypoxia and metabolic acidosis. So clinically, someone will just rapidly collapse, and then they have got lactic acidosis, those problems. And then they can be the patient can also be in an hypermetabolic state, so where there's going to be, this one is for persistent high metabolic rate after a major burn. And the consequences is there is a protein catabolism, which will lead to a negative nitrogen balance, and an increase in vitamin and micronutrient deficiency, which leads to malnutrition. And this malnutrition actually predisposes someone to immunosuppression. And then a high energy expenditure, which will lead to weight loss and muscle wasting. Metabolic acidosis also comes in, and the causes includes hypoxia, okay, for example, from carbon monoxide poisoning or pulmonary edema, that is going to lead to hypoxia, which leads to metabolic acidosis. And lactic acid accumulation because of poor tissue perfusion. What happens is that if blood is not going to the tissues, okay, the tissues will take another route. If nutrients and oxygen is not going to the tissues, they'll take another route. They'll start breaking down fat so that they use energy from the fat. And the breakdown of fats releases lactic acids. Okay. So clinically, there's going to be tachypnea, confusion, risk of mouth organ failure. All right. On the musculoskeletal system, you are going to see hypothermia. Basically, what happens is that someone will be losing heat, and it's because when there's an injury, burn injury, there's a loss of the skin, and that causes a loss of thermoregulation. So the burnt skin cannot really conserve or dissipate heat effectively. That leads to systemic hypothermia, okay, which is going to be worsened by loss of fluids and exposure uh, during resuscitation. So that's hypothermia. And then the compartment syndrome can come in when there is a circumferential full thickness bend that leads to an eschar. So an eschar will be like a tourniquet. Think a tourniquet is Think of you've tied your hand with a very tight bandage. Okay, that's a tourniquet, and that's how an ESCA behaves like, and so that leads to limb ischemia. Okay, so if you want to help with this condition, you need to do an escaratomy, like you need to remove the scar, surgery to remove that eschar. Okay, there can also be poor healing and ankylosing joint stiffness because of the scar and the contracture that is forming. Contractures can actually get to happen because of the scar, and that leads to shortening across joints, which leads to deformities, restricted mobility. Okay, and common bends happen over the flexor surface. And the way you can prevent these contractures is by doing some physiotherapy, splinting, or even eddy grafting. Nerve compression can also happen when, especially when there's a compartment syndrome, these contractures, and that causes neuropathic pain because of compression on the nerve. Okay, you cannot really tell where the pain is coming from. Weakness and also sensory loss. You can see these are contractures. Okay, these are contractures that can happen because of burns. Other complications that can happen in burns include urinary tract infections, bed sores because of immobility. UTI is happening because if someone has got a burn, you catheterize them for long, and that predisposes to UTIs, and then multi-organ dysfunction if shock and sepsis are not controlled. Okay, so the complications really in burns, you can divide them into immediate complications and late complications. The immediate complications, or sorry, the intermediate, not immediate. The intermediate complications includes infective complications, hematological complications like anemia, or anemia happens in burns. Initially, like the first 1 day, someone is going to appear to be having polycythemia, and that is because you are losing more of the fluid than the blood cells. So that's why for in the first 1 day you don't give blood, because they have got a lot. They are in actually what we call hemodilution. They are not really hemodilution, but they have lost its hemo concentration. They've lost a lot of fluid, but they've not lost blood. So they appear to be, the HB is going to appear to be so high. Please don't give blood in the first 1 day, okay, after a burn. Okay, so anemia is now going to happen later on, and that is because now the red blood cells will start to be broken down, and then on you are going to have GIT complications. These are also intermediate. Musculoskeletal complications, renal complications, other complications like septic arthritis, hypoproteinemia, ectropion, and amputation. The late complications include the musculoskeletal like contractures, okay, dermatological like hypertrophic scars, keloids, Majolin's ulcer, which happens later on, which is the malignant transformation, psychological and social problems. For example, after burns, there is a cosmetic disfigurement. Okay, someone is not looking the same anymore. So they are depressed, they are anxious, they want to withdraw from everyone else. So long-term rehabilitation will require also counseling and reconstructive surgery. Okay, on the GIT again, you are going to have esophageal strictures, pyloric stenosis. There is respiratory infections, and then systemic problems like thromboembolic events, DVT, pulmonary emboli, UTIs, bed sores, and severe malnutrition gets to come in. Okay, so that is it. We'll end here. In the next class, we'll now talk about how do we investigate a patient that has got a burn injury and how can we treat them.